as pain physicians and for what conditions we actually use different treatment options. In the beginning, I go over anatomy of pain. I'm going to breeze through this real quick, as most of you already understand that, but it helps me later on in the topic, in the talk. So, when you're treating a pain physician, or when you're a physician treating a pain condition, you have to think about the big picture. You have to think about all the different components that could cause pain. So we have to think of joints, nerves, bones, muscles, skin, organs, and of course the mind. What is pain? Back in 1968, McCaffrey described pain as whatever the experiencing person says it is, whenever he or she says it is. So it was very subjective. In 1979, the International Association for the Study of Pain kind of added tissue injury or potential tissue damage into that definition, which broadened its scope significantly. When thinking about the pain signal, we have to think about transduction, transmission, perception, and modulation. A key point of this topic, of this conversation, will be modulation, because we can modulate the pain signal with medications, with intervention, and with actually with counseling. Different types of receptors: mechanical, thermal, chemical, and polymodal. This is a very basic segregation of this, but it's nociceptive pain and neuropathic pain. Nociceptive is divided into visceral and somatic, and neuropathic is more from nerves and inflammatory conditions in the nerve region. We also have silent nociceptors, which are deep in the skin and in the tissue that can be woken up. They're normally unresponsive to noxious mechanical stimulation, but become awakened. One possible explanation of this awakening phenomenon is repeated stimulation can decrease the threshold and make them more likely to fire. This is one of the concepts of hyperalgesia and central sensitization, as well as allodynia. If you get hypersensitive nerve endings, they can be very hard to calm down. In the visceral organs, there are a lot of silent nociceptors that can be awoken with tissue damage and trauma. In general, inflammatory mediators bathe the nociceptors and cause an action potential that then propagates to the spinal cord and interacts with the second order neuron. So the dorsal root ganglion, bringing it into the second order neuron, going up the spinal thalamic tract to the thalamus and to the brain is the most common path to get there. There's A delta fibers and C fibers. The A delta actually are relatively fast, thinly myelinated pain fibers, whereas the C fibers are slow and unmyelinated. Most of their cell bodies are in the root ganglion, the dorsal root ganglion, or the trigeminal ganglion. And the reason I mention A beta fibers here is just because they are normal light touch and vibration fibers, but they have collaterals to the pain pathways, and they can help modulate the pain signal. So we have our primary afferent, A delta and C. Then we have our second order neurons, and then we have our modulation. So modulation is the majority of the focus for this talk. The way that we modulate the pain signal is through the descending tracts. Typically norepinephrine and serotonin are common ones that we target with medications to help suppress the pain signal. The periaqueductal gray and the nucleus raphe magnus are both centers in the brainstem and the medulla that if you stimulate the periaqueductal gray, it interacts with the nucleus raphe magnus and produces serotonin type downregulation on the pain signal, signal coming up the spinal cord. The periaqueductal gray does get input from the thalamus, the hypothalamus, the cortex, and from collaterals from the spinal thalamic tract. Both of these tracts, when stimulated, can produce analgesia. The periaqueductal gray when stimulated, can produce endorphins and natural opioids, which help suppress the pain signal as well. The raphe nucleus, when it's stimulated, produces serotonin. And our own endogenous opioid system is quite useful in self-regulating the pain signal and keeping it at bay. Most of this information comes down through the dorsolateral funiculus. So if you sever this, you have a significant decrease in the downregulation of the pain signal coming up the spinal cord. This carries information not only from the periaqueductal gray and the raphe nucleus, it also comes from adrenergic neurons coming from the locus coeruleus and the ventral tegmental area dopaminergic input. So that very quick, brief overview of the pain pathways and how they work is mainly meant to get to this gate control theory of pain. So many of the mechanisms that we use in pain, including TENS units and spinal cord stimulators, access the gate controlled theory of pain and help block the pain signal coming up the spinal cord. If you provide non-painful input, meaning normal vibration or touch, it can prevent the pain input from getting to the central nervous system or to the brain. When your grandma told you, why don't you rub that sore because it makes it feel better, she wasn't kidding. That actually has a very clear mechanism that we use on a regular basis to treat pain. There's an inhibitory interneuron that actually blocks that pain signal from the nociceptive fibers. So peripheral sensitization is one of the ways that the pain fibers get used to sending signals, and they can increase the intensity with which they send the signals over time. If you have inflammatory mediators that consistently put stimulation into the nociceptors, these can sensitize these nociceptors, make them have a lower threshold for activation, and increase the rate of firing, therefore amplifying the pain signal. So if somebody has a constant input of pain, it can slowly make the pain more intense regardless of the stimulus changing. They generate nerve impulses more readily in the periphery, and this aids to sensitization in the central nervous system. So the central nervous system has spinal neurons that become hyperexcitable as well when overstimulated or repeatedly stimulated, and it creates a slow progressive windup of the pain signal, including NMDA receptors in the secondary neurons, and it causes reduced central inhibition. Even the dorsal horn cells in the spinal cord can spontaneously depolarize and send a signal, and it also recruits the normal receptors and pain fibers to produce a painful signal. One of the ways that the NMDA plays a role is it's a secondary neuron, and it becomes more activated and sends a signal quite intensely that often gets improved with NMDA receptors, and we'll talk about that later. All of this central and peripheral nervous system sensitization leads to the phenomenon of hyperalgesia and allodynia. Hyperalgesia being an increased response to noxious stimulus, and allodynia being a painful response to a normal stimulus. I'm going to skip this slide other than just to say that this is a wonderful technique to use mirror therapy to help with phantom limb pain. Phantom limb pain is a topic on its own. I was going to get into it a little bit, but if you ever have somebody with phantom limb pain, do provide a physical therapy referral and consider mirror therapy, because I've seen amazing things happen. Basically, they just take the normal limb, put it to where the person can see it in the mirror, and they think, or not they think, but their brain registers the mirror image as their residual limb, and you touch the limb that is normal, and their brain can kind of resensitize and decrease the hypersensitivity of that pain signal from the limb that has been lost. Okay. So big picture for treating pain, we have several different modalities we can use. Number one being medicine. Intervention is largely where I come in. Surgery, psychology, mindfulness, exercise, massage, acupuncture, myofascial release. Very important to treat holistically or multimodal approach to pain management, because any one treatment in itself is not going to be sufficient. Medicine, I hate to say that I'm going to go over that briefly as well too, because I just went over the anatomy briefly, but you guys probably know a lot about the medicine management for pain. The main categories that we use are local anesthetics, NSAIDs, NMDA blockers, anticonvulsants, tricyclic antidepressants, SNRIs, and opioids. I love this slide because it shows you the different places with which a lot of these things work. I don't like how faded it showed up on this image, but you can see the lidocaine and the capsaicin work in the periphery, and then the dorsal horn is where a lot of these opioids and TCAs and NMDA blockers work, where the primary and the secondary neurons interact. Pain signal typically goes through the NMDA receptors when you have that wind-up of the central sensitization. Now, this is where we get into the intervention, which is what I've been rushing through to get to. Focal nerve entrapments and compression are where we spend a lot of our time as pain physicians focusing on. Spinal canal stenosis and radiculopathy are common things that all of you see on a regular basis. Lower back pain is one of the #1 reasons people come in to see primary care. Spinal canal stenosis can have neurogenic claudication associated with it or not, and it can have bowel or bladder incontinence associated with it or not. That determines the severity and the importance of how quickly you treat these conditions. Radiculopathy typically will come from a neuroforamen narrowing or a lateral recess stenosis. EMG, I don't know how much you guys use EMG or if any of you perform EMGs. EMG is an invaluable resource when it comes to radiculopathy. If you have a normal sensory nerve action potential, but you have signs of denervation in a particular dermatome or myotome, it means that the dorsal root ganglion is still intact, and it is proximal to that dorsal root ganglion being a radiculopathy rather than a peripheral nerve entrapment. The peripheral nerve entrapments would be distal to the dorsal root ganglion, which would show up as sensory nerve action potentials that are inhibited. Epidural lipomatosis is another common thing that we see often on imaging. You see it and you don't think much about it. I have seen many cases where they come in and the fat is pressing on the nerves, and you do an epidural and it necroses some of that fat and they feel better. There is a caveat where there is endogenous opioid steroid use can cause a hyperproliferation of the fat, increasing the pressure on the nerves, and it can be a contraindication to treat with an epidural steroid injection. So we don't always know until we try how they're going to respond, but you could make the patient worse if you do an epidural with the lipomatosis. Peripheral nerve entrapments are plentiful. You can pretty much anywhere where a nerve comes across a bony prominence, or whether it has a fascial muscle attachment that can push on it, you can have an entrapment. Greater occipital neuralgia, pushing on the base of the occiput, you can feel a predictable radiating pattern over the top of the head. It can be entrapped where the attachment is at the base of the skull for the levator scapula muscle and the splenius capitis. As far as the lesser occipital is just lateral to that, and it can cause a sensation over the top of the ear that is quite painful. Thoracic outlet syndrome, brachial plexopathy, both can cause pain mimicking radiculopathy down the arm, so you have to think very carefully when you come. Somebody has pain, numbness, weakness, down the arm and you're thinking possible radiculopathy, don't rule out the brachial plexus or the thoracic outlet if the MRI of the cervical spine looks fine. EMG, if a good EMG technician or a physician is working on the patient, they can differentiate the thoracic outlet from the brachial plexopathy. Suprascapular nerve, that's a common entrapment, kinda, not really. Maybe with the injuries you can get it. I had one the other day that was a very astute neurologist localized the entrapment to the spinal glenoid notch. The suprascapular nerve innervates the supraspinatus and the infraspinatus and can mimic shoulder pain. The EMG had a normal supraspinatus, but an abnormal infraspinatus, so it was entrapped in the supraglenoid notch. We did an injection in that notch and she felt a lot better. She's considering surgical options because it only lasts about 2 months, the block. Axial nerve, ulnar nerve, we all know the cubital tunnel, Guillen's Canal, median nerve, carpal tunnel. There's, I guess I could go on for hours on all of this, but piriformis syndrome is a very common finding, mimicking sciatica. If they have piriformis muscle which goes from the sacrum out to the greater trochanter, if it puts pressure on the sciatic nerve, it can mimic a radiculopathy down the leg, and it can be quite confusing. You get an MRI, and the MRI looks fine in the lumbar spine. You get an EMG, and it localizes to the sciatic nerve at the piriformis. Physical therapy and injections can help with that. Lateral femoral cutaneous nerve is a numbness down the front of the leg, often happens with a tight belt or police officers that have a lot of weight on their belt. A pannus that hangs over can tug on it sometimes, and that's treatable with an injection. Common peroneal nerve injury is often, or entrapment, can be confused for foot drop from a radiculopathy. EMG is excellent at localizing this. Same with the tibial nerve, can mimic an S1 radiculopathy on the bottom of the foot, or a soleal sling syndrome. That's just where the soleus muscle fascial attachment at the proximal end can compress the tibial nerve and mimic a radiculopathy. When you're approaching, so that's peripheral nerve pain, so or nerve entrapment, central or peripheral. Somatic pain, you have to think broadly as well. For joints, tendons, bursa, you have to think very carefully about gravity forces. Being a physical medicine and rehabilitation trained physician, watching people walk is invaluable. If you see how their gait is putting pressure on different parts of their anatomy, you can almost predict where they need to correct it or inject it to get their pain to resolve. Leverage, as far as if somebody's center of gravity because of scoliosis is off to the side, their tensor fasciae lata and their gluteus maximus muscle, when they stand on this leg, has to work a lot harder to hold their gravity above center line. And so you can get greater trochanteric bursitis and different pain in the hip, increased pressure on the hip, just because of their anatomy. Laxity is a very important thing to evaluate. If somebody has knee pain, shoulder pain, wrist pain, if you really manipulate that joint and see if the ligaments on either side are too lax, you can imagine a joint slopping around too much will produce more inflammation and more pain. Not only should you inject it with a little bit of steroid to calm it down, you can also use prolotherapy and different injections to tighten up the ligaments and hold the joint into a more stable position. The general approach to back pain is similar. You don't want to think nail just because you happen to have a hammer. So as pain physicians, we have to be very careful not to say, I can inject that, I can inject that. You know, just because we have that ability doesn't mean that's what the patient needs the most. Looking at lower back pain, you have to think very diffusely. Is it disc? Is it facet? Is it ligament? Is it muscle, fascia? Is it a scar that they had from a surgery that's tugging on a nerve or entrapped a nerve? And not to forget the organs, because organ pain can radiate to the back quite often, and it can be tricky to diagnose. Types of pain is very important. So neuropathic pain, if you have burning, tingling, Shooting pain versus somatic pain is a deep, achy, dull pain. Organ pain is very often a diffuse pain and it's hard to localize. And aggravating factors and alleviating factors. Patients, if you sit and listen to them and you give them a chance to truly talk, will tell the exact story of what upsets their pain. And from that, you can usually have a good idea where it's coming from. If they do spinal extension and rotation, it can be the facets. If they have to lean forward when they're walking through the grocery store, their legs get weak and they have to sit down, it's spinal stenosis. Physical exam, priceless. Listening to the patient, priceless. So, stenosis in greater detail. A lot of this you probably already know. Spinal canal stenosis can compress all the nerves below it coming down through. Usually it is a triad of things that can cause the spinal stenosis. In the anterior aspect, you have the disc that can push posteriorly and compress in the canal. On the posterior element, you have facet joints that, if they become arthritic, can push in from the posterior aspect. If you have any instability, this ligamentum flavum becomes quite thick because it's trying to help support that segment that has extra motion, and it can enlarge and push into the spinal canal. So spinal canal stenosis is not just the disc. It is a very complex with many different components that help cause it. You can have neurogenic claudication, which is pain exacerbated by walking or standing upright for long periods of time. The patient will very much tell you that they just need to lean on the shopping cart, or they need to sit down after walking a certain distance because their legs feel weird, or they just feel heavy. It doesn't have to be sharp burning pain down the legs. It can just be a sense of heaviness. Congenitally short pedicles can also lead to this spinal stenosis. I forgot to mention that. A lot of people, their pedicles just weren't long enough and they don't have a lot of space, so any small disc herniation can cause compression on the canal. That makes it a difficult patient for surgery because they have to do multiple levels of surgery to get relief, which involves fusion. So back to the neurogenic claudication, usually leaning forward 20 to 40 degrees will relieve the neurogenic claudication symptoms. And often the straight leg raise is negative. I remember getting into a discussion with the medical director at Presbyterian because they were not approving an epidural steroid injection because there was not a straight leg raise positive. And on spinal canal stenosis, you don't have to have that, but it can cause debilitating pain that does improve from an epidural. This needs to be differentiated from vascular claudication. Vascular claudication, they don't have to stop. They can walk and then they get pain in their legs, kind of a burning pain in the feet usually. They stop, wait a few minutes, the blood flow finds its way to the feet again and the pain goes away. They don't have to sit down. Spinal canal stenosis with neurogenic claudication, they do pretty much say that they have to sit down. And the neurogenic claudication symptoms typically come from ischemia. So when you stand up and there's pressure on that canal, it actually decreases the blood flow to the nerves, which then sends that pain signal, and that's why they have to sit down. They have to re-vascularize their nerves. Venous congestion and diminished arterial blood flow cause a decreased impulse in the nerves. So radiculopathy is similar to spinal canal stenosis, but it's usually in a very predictable dermatomal, myotomal distribution. Nucleus pulposus can cause chemical inflammation on the nerve if it actually enters the epidural space. It's not used to being there. So if that material is present, it causes significant irritation of the nerve root itself. The cervical spine, if you have compression of the discs in the cervical spine, the joints of Luschka, which are the uncinate joints of the vertebral bodies, hypertrophy and get bigger, and when they do, they can tighten in on the neuroforamen around the particular nerve ending at that level and cause a focal neuroforaminal stenosis. The lumbar spine is similar. They don't have as much of the bony hypertrophy of the end plate, but they do have a generalized decreased disc height, which can then decrease the neuroforamen and be enough to cause a radicular symptom. Treatment with epidural works in many different ways. It actually washes away the inflammatory mediators. So when you have either a disc material present or a continued pressure on the nerve, the immune system does cause an inflammatory cascade, which then does stimulate the nociceptive fibers. They have shown some studies that if you just inject saline and wash away those inflammatory mediators, it almost works as good as steroids in some cases. If there's continued pressure and continued inflammation, it's not as good as steroids because the steroids actually suppress that for longer. The steroids can interrupt the inflammatory cascade, and you can use clonidine. If somebody is having major problems with glucose or diabetes and they can't get the steroid, or they have an allergy to steroid, you can use clonidine. It's an alpha-2, and it can block the pain signal. Not as quick as steroids, but the studies have shown it's almost as long as the steroid dose itself. Radiculopathy with these patterns, the patterns are quite predictable based on which level you're treating. I love this author, Hoppenfeld. Brings me back to medical school days, but I still use it because the motor, the reflex, and the sensory, I'm always thinking this. Anytime anybody's looking at me for a pain diagnosis, this is always in my mind. Do the reflexes match the weakness motor-wise, and do they match the sensory deficit? So C6, C5 with the biceps, reflex, and the sensory deficit, C7 triceps, middle finger, wrist flexors and extensor and finger extensors. So always thinking about that. As far as the epidural steroid injections, we have to be a little bit careful with the treatment because we are getting close to the spinal cord. In the cervical spine, we used to do transforaminal epidural steroid injections all the time for a particular level of nerve entrapment. There were a few cases of death, spinal cord injury, and paralysis from those injections. The vertebral artery is very close to the neuroforamen. The neuroforamen, the angle that you're taking to get into the neuroforamen is pointing directly at the spinal cord. So there's a lot of way, and the particulate you're injecting can get into the artery and cause a stroke. So there's a lot of risk associated with that. The pain community is shied away from that now and are recommending mostly intralaminar at the C7T1. We still do the cervical transforaminals if needed. If somebody's had a posterior laminectomy infusion and the dura is adhered to the epidural space, then coming from the bottom it won't always spread. We can either use a catheter or we can do a transforaminal above it. Lumbar transforaminal, the radicular artery is right there, and it does cause blood, it does provide blood supply to the spinal canal. So if you inject particulate in the transforaminal space, you do risk getting it into the radicular artery and causing a spinal cord infarct. There's several ways to get around that. You can either use dexamethasone, which is a non-particulate, and it won't clot the artery and cause, even if you inject into it, it won't cause damage unless it spasms for a long period of time. Or you can use live contrast. So we'll use a tubing, with contrast live to see if it flushes up into an artery, and sometimes we'll still use particulate in the transforaminal space, but typically dexamethasone. Another option to treat is from the caudal space. Here down on A, you can see coming in from the base of the spine with an epidural. This is the contrast that's about as far as it spread. Sometimes you can get it all the way up to L4. This is contrast with a catheter, so you place a little catheter into the caudal space and you inject the contrast, that's where it spread. This is with hyaluronidase and hypertonic saline. You can actually do hydrodissection, so if somebody's had a surgery and the scar tissue is adhering and tugging on the nerves, you can gently push a little bit of saline in there and try to hydrodissect, and then the medicine will spread further. What I found is usually it's not that injection that helps the most, it's the next one. So whatever the hyaluronidase is doing or the saline, the next time it spreads much better. Discogenic pain is a very common but difficult to diagnose condition. At first, it was a big controversy because they didn't think that the disc was innervated in any way, shape, or form. Then they started to find that the outer annulus, the outer 1/3 of the annulus, was innervated, and with injury,
the nerves actually grow
they
into
found
the
that
injured area, so you can get further innervation where you didn't have it before. Discography was one of the ways that they developed to determine if disc pain is happening. You put a fairly large bore needle into the disc at multiple different levels, and you have to have a normal level that you go into as well. You push contrast in at a certain pressure and volume to see if it reproduces the pain that the person had. It's still controversial whether that actually works or if the risk is worth the benefit, because you do penetrate the disc that wasn't penetrated before. Some surgeons still ask for it, but we don't do it that often anymore. One thing you can do is since the sinovertebral nerve innervates the posterior element and the rami communicans innervates the anterior component, you can do a lumbar sympathetic block and a transforaminal epidural, and that should take care of the majority of the disc pain and at least give you an answer. Regarding the studies, early studies did show about 70% of discs with a grade 3 fissure were painful, and some 70% painful discs had a grade 3 fissure, but it's really not that clearly associated with disc pain. You still have to try things and see what you can do, and you often have to rule out the other things first. I already covered that. So we covered the pinched nerve, the spinal canal stenosis, radiculopathy, neuroforaminal stenosis, and disc pain. Facet joints are a very common source of pain for people. Facet joints are the only synovial joint in the spine. It has hyaline cartilage over a subchondral bone. It has a synovial membrane, and it keeps joint fluid inside. As far as the capacity is about 1 to 2 milliliters of fluid that it can hold. It is the posterior articulation of every vertebral body segment. So in the anterior aspect, you've got the vertebral body and you've got the discs. That holds 50% of the weight in any one segment. The other 50% is shared right and left between the two facet joints in the back. So they each take 25% of the weight. If you degenerate a disc and it decreases the pressure, decreases the height here, the facet joints take more weight. If you have a compression fracture in the vertebral body and it decreases height, the facet joints take more weight. So they can be a major contributor of pain. Each facet is innervated by 2 nerves. So in order for that facet to feel pain, it goes through 2 different nerves. So the level above and the level below. If you look at some of the pain doctor's notes, you'll see I treated L4-5 facet joint pain with an L3-4 block, and you'll be wondering why do they do that? Because the terminology in the lumbar spine is a little different. In order to treat the L4-5 facet joint, you have to denervate the L3 and the L4 medial branch. This little muscle here, the multifidus, does have innervation from the medial branch, and so if you do a medial branch radiofrequency ablation and you burn that nerve, you can get temporary weakness in the multifidus muscle in the back. Usually it's not clinically significant, and it does reinnervate from local nerves in the vicinity, but the people that have had multiple laminectomies in the past at other levels or have major kyphoplasty or compression fracture deformities, they can notice a significant weakness temporarily after the procedure. Imaging findings don't necessarily correlate with facet joint pain, so you can do a physical exam, find somebody that has pain in their facets and look at the x-rays and the MRIs and they look fine. It just means the arthritis hasn't kicked in yet. It doesn't mean that there's not inflammation there. So we can do a very simple block where you just numb the nerves to the joint and it'll give you a pretty immediate answer whether the joints are causing you pain. The facet joints radiate a fairly distinctive pattern of pain. In the cervical spine, the C2-3 will be at the base of the skull and over the top of the head a lot of the time, similar to a greater occipital nerve distribution. The 3-4 is a little the side of the neck pretty much, and then the 4 or 5 starts to drape over the shoulder. So insurance only lets us do 2 or 3 levels of facets at a time, so we really rely on the patient telling us where their pain is to choose the level that we're allowed to treat from the insurance. Thoracic is fairly straightforward. The lumbar spine often mimics the pattern of sciatica. They just won't have the burning pain. They'll just have a deep, achy pain. A lot of people I've found, I can't say I have a study on this one, but I have anecdotally in clinic, they have told me, I feel like I have restless leg. I feel like my legs just want to move. You treat the facet joints and that symptom goes away. And so I'm pretty impressed with that concept, because a lot of people have restless leg syndrome, and it may just be from their joints.
Can you stop there? What is the lumbar there, the green versus the blues? What?
You know, so the dark blue is the, oh no, I don't have it here, do I? So I'll have to get back to you on that, but I believe that this is the 2-3, and this is the 3-4, the 4-5, and the 5-1. But I don't remember. So people that
come in and they talk about iliac crest area pain, that's always something that I
posterior or in the
more lateral and anterior.
Lateral and anterior.
Yeah, and X-ray's not really showing anything on the hips.
Sure. So
go ahead.
I would put him through a physical exam and see if I can reproduce it. So a lot of the times the tensor fasciae lata on the anterior aspect, based on their pelvic obliquity or how they're walking, the gluteus maximus can kind of irritate on the posterior, and then the rectus femoris on the anterior aspect, and then groin pain, if they have anything that goes from the iliac crest down to the groin, I'd kind of look at the hip a little bit, or hernia. And then if it's a little bit above the iliac crest, I'd put them through an abdominal stress test, basically to see if the attachment of the rectus abdominis or transverse on that iliac crest is irritating. Because a lot of people, I don't know what they do, but they pick something up or they golf, and they just tear a little bit of it away from the iliac crest. But so yeah, so that I don't know if I have seen get better with the facets. I have seen the facet joint pain across the back and radiating around into the front that I thought was hips at one point, or SI, and it got better with the facets. So as far as the confirmation, it's imperative that before you do a medial branch block trial to see if it's coming from the facet joints, that you've ruled out other pain. If you have disc pain, spinal stenosis pain, radicular pain, and you do a medial branch block and they only get 25% better from the block, you don't really know if you do a radiofrequency on that, it'll make them feel a lot better. So you have to treat the other things first to get an accurate reading. Plus, insurance won't cover it unless you have 80% relief. So you have to rule out the other stuff first. The facet joint effusions I put in here because surprisingly common how often you find those when you look at an MRI. And if you just drain those with drain them and then inject a little bit of steroid in there, a lot of people don't need much else to treat their back, and you get them into physical therapy and they do a lot better. Plus, if there's a cyst that forms from the facet joint, which is not uncommon, the facet joint, if it gets too much irritation and it starts to produce too much fluid, it can bulge out the capsule. That capsule, if it's got pressure on it, can actually push on the canal or push on a neuroforamen, depending on where it goes, and you can easily drain that or rupture it. You can just put enough pressure into it to pop it, put a little steroid in there, and often it won't come back. The spondylosis and spondylolisthesis and spondylitis, if you have a fracture of the pars interarticularis, that can make the spine very unstable. Happens a lot in young athletes. It just never formed completely, and then they come to you as either a young adult or an older person, and this slippage forward of one on the other can cause pain on the facet joint that's trying to resist that movement, plus canal stenosis and neuroforaminal stenosis, plus the shearing pain on the disc. So this is a very complex problem that often will require surgery, but sometimes you can treat with an epidural, calm down the pressure on the nerves, and the disc, and then do a radiofrequency ablation, get them into core strengthening with their psoas muscle on the front, and they do a lot better. The oblique view is how we get the Scotty dog image to see if there's a fracture at the neck of the interarticularis. Treatment options for the approach to facet, typically we'll do a medial branch block trial first. So we just numb the two nerves that relay the information of pain from that joint to the brain. If the pain is better during the course of the local anesthetic, say you use lidocaine, you get 4 hours of relief. If they take home a diary and they say, wow, for 4 hours I felt like a new person, and then it wore off, you know that's where it's coming from. You have to do that twice for insurance to cover it. After you've blocked and you figured out, yes, this is where the pain's coming from, you can either choose to do a radiofrequency ablation to burn the nerves and denervate it so you don't feel the pain from those joints. Or you can do an intra-articular joint injection with steroid, which doesn't last quite as long. But a lot of people they hear the burn and they get afraid. They don't want to do the burn. It's not really a cauterization, it's more of a transfer of heat through a radiofrequency wave, but it scares them. Fusion is another option to treat the facets. During the procedure, it's a pretty straightforward procedure. This is the block. We just numb the nerve by the superior articular process and the transverse process. This is the intra-articular facet joint injection, just putting the contrast and the medicine inside the joint. This is the radiofrequency ablation, laying it down at a different angle, but basically heating up the tip of this needle until that nerve gets denervated. Typical setup, very similar to the facet joints. It's not that intimidating. You lay down the same way you would for a facet joint, and you just have the probe that is about the size of a needle, and it just heats up the tip. We stimulate first, so if you imagine this is where the medial branch is that feels pain from the joint, this is the actual nerve to the leg that provides motor and sensory. So we are putting it close to that nerve, and there is a risk that you can cause paralysis or paresthesias that are permanent or numbness in the distribution of this nerve root. So I tend to keep the patient awake during this process, and then what you can do is you can stimulate with 50 hertz for sensory and 2 hertz for motor, and they will tell you whether this is touching that nerve before you burn. So it's a fairly safe procedure if you kind of take the precautionary measures. New studies show that anatomy should be enough. You don't need to do these tests. I still do them. Radiofrequency ablation is a 5 to 10 millimeter active tip. First developed in the 50s for cardiac, 75 for pain. It does get up to 60 to 90 degrees Celsius, so it is quite a temperature change for that nerve, and it denatures the proteins and doesn't allow it to function any longer. You do it for 60 to 90 seconds. The mechanism of action is hypothesized to be twofold. Basically, 45 degrees Celsius is the threshold for nerve damage, so direct thermocoagulation of sorts. Really, it's more of a, where do I see that? I'll explain that in a minute, but it's really a transfer of energy. It's not a heating up of the tip of the needle. The second mechanism of action is the electrical field that it creates around the C fibers. This Slutzker proved that at 42 degrees you could have very good relief, and that is not hot enough to cause a denervation of the nerve, and so the hypothesis was that the electrical field produced modulation of the dorsal horn cells. Unfortunately, insurance does not pay for pulsed radiofrequency ablation, so unless you get it above 45 degrees for a certain duration of time, they won't pay for it. Otherwise, I would be doing a lot more pulsed. This is what the lesion looks like based on the size of the needle. And it is not without risks like we discussed previously. You can also do radiofrequency ablation for joints. So a lot of people come in and they have a replacement already and they still have joint pain. So what do you do with them? They have cancer pain. that's quite significant and they can't seem to get it under control, or they're not a surgical candidate due to comorbidity. So you can't put them under the knife for replacement. So you can denervate some of the nerves that feel pain from the joints. In the hip, it's the sensory branch of the femoral and the obturator, so it doesn't take care of all of the pain, but it can help significantly. The knee, it's the superior medial and lateral and the inferior medial. You can't do the inferior lateral because you could get foot drop. So you get about 75% relief for the knee pain. Shoulder is very similar, but supraspinatus and intraspinatus are innervated by the same nerve, so you could get weakness in those muscles. We prefer to do pulsed with this particular procedure. Need more placebo-controlled studies. 2018, there are 14 studies for RFA of the hip, showed pretty good relief up to 36 months. Lack of serious adverse events, which is good. Genicular nerve, they assume that you can cause vascular damage because the blood flows very close to the genicular nerve, but there are no reported studies of vascular insufficiency or damage after a radiofrequency. Same thing for the shoulder. Artery lays right next to the nerve, so you do a radiofrequency there. I really prefer to do pulsed in the shoulder. Bursitis, I'm going to skip. SI joint, don't forget about the SI joint, especially in pregnant women that have delivered and now they're trying to recover. SI joint can be horrible because the relaxin that separates the joint and then it has to find its way back together again, and it can kind of get stuck. Alignment and motion, I already talked about this. Always look at your patient and how they walk and try to correlate where that pain could be coming from. Okay, I'm running out of time, so I'm going to run through these fairly quickly. Fracture pain, we do kyphoplasties and vertebroplasties for. There is a risk that you can have, because of osteoporosis and insufficiency fractures or tumors, you can have fractures in the spinal vertebral body quite often. Minimally invasive procedure, you put the needle in, you expand a balloon to create a cavity, and then you deflate the balloon, you pull the balloon out, then you put in the cement and it interdigitates with the trabeculae and creates an internal cast. Also, the heat of the cement is hypothesized to burn some of the nerves or damage the nerves inside that cause pain in the bone and can help. Background on osteoporosis, I'm sure you guys are familiar with that. It's quite common. There are risks associated with this procedure. So pulmonary embolus can be anywhere from 3.5 to 23% with this procedure because it can get into the vein and the cement can spread. It's very important that you watch live under x-ray while you're doing this, and you can see the contrast spread. You can see it not go into the vein and cause this issue. And it can happen up to a year afterwards, which nobody can really, I haven't found a good explanation of other than maybe a piece of cement broke off. So it's 12:53. Complex regional pain syndrome is my last topic in spinal cord stimulators to help treat this kind of thing. Complex regional pain syndrome, type 1 was reflex sympathetic dystrophy, type 2 used to be known as causalgia, also known as sympathetically mediated pain, more common in young patients, usually due to immobilization or trauma. If they have psychological factors, such as poor mechanisms of coping with stress or other underlying conditions, it can make this condition much worse. Diagnostic criteria, you have to have some sort of an event that caused it, continuing pain and allodynia or hyperalgesia it's not proportionate with the actual insult. So they have excruciating pain, swelling. You can even have pseudomotor changes and sweating. The temperature changes are typical in about 42%, and if it gets really bad, you can actually have hyperkeratosis. So I'm going to skip to the injections. The sympathetic nervous system is involved in this usually, and so on the front side of the spine you have all your sympathetic chain, It's a balance of fight or flight, parasympathetic and sympathetic, and with a constant stimulus like we talked about with the central sensitization and the peripheral sensitization. If you have a constant impulse, it can upregulate the pain signal. It can also increase your sympathetic outflow, so it can increase the pain that you're perceiving. If you block it with nerve blocks such as stellate ganglion block, lumbar sympathetic block, ganglion impart block, these are blocks that you can do to see if it helps the sympathetic pain. If they respond well to this, but the complex regional pain syndrome continues to spread, it gets so painful in some people they just guard their arm and they won't move it. The wind just touching against it is excruciating. The worst thing they can do is guard it. So you send them to physical therapy, you do fluidization, which is desensitization of the nerves. You basically train those nerves to feel normal again. And if none of that works, then you can put in a spinal cord stimulator. Spinal cord stimulators are hardware that you implant into the spinal epidural space, and you implant the battery underneath the skin. Mechanism of action is thought to be the gate control theory of pain, but that's not the only way that it works. It also stimulates the large nociceptive A beta fibers. That is the gate control theory of pain. It inhibits the A delta and the C. It also works with GABA B and adenosine. And they even found that substance P, GABA, and serotonin were released when the spinal cord stimulator was used. They also decrease the hyperexcitability of the dorsal horn fibers. And new studies are showing that what U.S. News was so upset about. All right, questions? Sorry to run through the last part like that, but I just wanted to get you out of here on time.
Just so you guys know, internally within the system, we do have 2 pain clinics. So Dr. Raiten practices at the Loveless UNM Rehabilitation Pain Clinic, which is downtown in the Medical Towers building. It's actually in the middle of a remodel. They're on the 3rd floor right now, but we're remodeling a suite on the 2nd floor. So in about a month, that clinic will move and it'll be beautiful and brand new and everything. But that's where he's at. We also have another location at the Women's Hospital at 101 Hospital Loop, the location behind Women's Hospital. So you can refer either place, or you can just send a general pain referral through Epic, and Iva's team will get them where they need to go and check wait times and things like that. Access is pretty good.
Yeah.
Right now you can get a new patient into either clinic very quickly. So if you have patients that you need to send, you should have no trouble getting them in.